The organizing committee of IFNR for inviting me for this guest speaker. Today I will be speaking about post-stroke upper extremity rehabilitation from a clinical perspective. So, the idea of this presentation is to share some views and experience of what to do, how to do in post-stroke upper extremity rehabilitation from an occupational therapist perspective, especially from an Indian background. First, we will see what to do first. So, the answer is a diagnosis-specific and prognostic-oriented, evidence-based treatment plan. So, what is diagnosis-specificity? Therapy planning should be based on the precise diagnosis of stroke. I would like to explain this concept with a simple example. A 20-year-old male civil engineer with left hemiparesis. He came to our center with a chief complaint of inability to or difficulty to eat from buffet system. On evaluation, brainstorm recovery stage for hand was 6/7 and power is approximately around 4+5. So the activity analysis showed that he had inability to maintain the plate properly in the horizontally, even though he knows what is the correct method of holding it. Why it had happened? It was like right MCI involvement of right parietal lobe. So perceptual motor aspect usually is a neglected domain in early upper extremity rehabilitation. We will be talking about this little later. So in addition to this, and diagnosis will give lot of other information. For example, an infected gangliocapsular region that will produce usually pyramidal and extrapyramidal symptoms like spasticity in both agonist and antagonist. So, but it is neither clasp knife rigidity or clasp knife spasticity or cogwheel rigidity, but it is just spasticity in both agonist and antagonist. This is what called as plastic rigidity. The advantage is that if this plastic rigidity is there, it is easy for us to make that hand as a supportive hand. About supportive hand, I will be discussing little later. Similarly, the probability of recovery, the recovery after an infarct at cortex level would be better than the infarct at corona radiata than at the posterior limb of internal capsule. So, why this is important? It is to predict the prognosis. Why we should predict the prognosis? Like Mark Venn said, you must always be able to predict what next so that we can avoid if we have flexibility to it. So how we should predict prognosis? So number one is based on the area and or type of brain damage. For example, patient with anterior circulatory infarct or right hemispheric stroke, visual gaze deficit, all those people will have a poor recovery usually in terms of upper extremity recovery. Second is initial degree of motor impairment. As we know, a severe paresis of one side will have a poor recovery than a mild paresis. Similarly, active finger extension and shoulder abduction in the first 1 week after stroke, which is a strong predictive factor to say that that hand will get moderate, quite good recovery. Then the other factors are like time of initial medical intervention, presence or absence of cognitive impairment, which is very critical. I will explain it a little later. So based on all this, in my clinical practice, I will divide the patient population into 3 groups roughly. So the group 1 is functional hand, that is the outcome. The second is supportive hand, and in the third group, a non-functional hand. In a functional hand group, their complete to functionally adequate recovery will be there. 40% of people will get complete recovery, whereas 38% will get a moderate recovery. There will be mild clumsiness in the hand. And for them, we can go ahead with the remediating intervention. For the group 2 supportive hand, there will be partial recovery, especially in the proximal limb. They will be able to do weight bearing on their affected extremity. There may be gross grasp in that hand. So with that grasp, we can do gross lifting activity. This belongs to this involves 30 to 50% of the population, and here we will go for both remediating and compensatory interventions. The third group is non-functional hand, they usually get a poor recovery. Usually, if the patient is dense hemiplegia, or I'll be explaining a little later about that. So here we will be going for compensatory interventions, like teaching one-handed technique for the sound extremity, and also we will be giving intervention to prevent further TCDs, tightness, contracture, deformities, and all other secondary complications. So now we have come to the second question, how to do it. So this I will be explaining for each group one by one in turn. So first we will see the intervention for group 1. So for an overview, it's a continuous process with considerable overlap between each stage. So intervention for group, to understand, step 1 is to understand or management of key visual, perceptual and cognitive deficit. This is the key aspect of the intervention to group 1. So as we know, the cognitive as well as visual aspects are the windows to start with the upper extremity rehabilitation. If this is not there, patient will be understanding the need and utility of the exercise. So the deficits like diplopia, photosensitivity, hemianopia, neglect, emotional ability, the therapist should have an awareness. If possible, we should manage these deficits as much as possible. The second step is eye, head, trunk coordination. Again, as we know, in order to carry out any hand function, first important thing is like the person should have a need of doing it. In order to have a need, we have to have a visual recognition of that object or that task. In order to have that, we need eye, head, trunk coordination. So traditionally, in the conventional method, we will be training these strategies system-based by different control systems. For example, for the eye coordination, we will be presenting a stimulus in front of the core visual field. Then for the eye head control, we will be presenting the stimulus in peripheral visual field. For the trunk eye head trunk coordination, we will be presenting the stimulus slightly in the peripheral visual field. So with that, we will be giving training traditionally, which we all know. So the contemporary method is like incorporation of virtual reality. This again I will explain a little later. The step 3 is training for reach. So the key challenge here is very important. It is how to overcome the effect of gravity to the paralyzed extremity. That is number 1. The number 2 is weight of the upper extremity over a relatively unstable shoulder joint. So how to overcome it? It is for this purpose I have designed a simple equipment. This is upper extremity unweighing system. This offers partial to complete unweighing of the affected extremity. It is simple and very much affordable and virtual reality compatible. Its limitations are it allows only 2-dimensional movement, like forward, backward movement and medial lateral movement. And graded unweighing, like the other robotic device, like 80% of unweighing, 60% of unweighing, which is not possible, but we can manage with the virtual reality game. So coming to the parts of this device, so there is a rail, a mobile rail on the left hand side, as you can see in the picture. Then second picture shows the controlling mechanism of the like medial, the horizontal movements we can actually control with that device. And in the third picture, as you can see, the axis of rotation of this device is much closer to the axis of shoulder of the person who will be sitting on that chair. And the fourth picture depicts the harness which I am using for this. So this is a person with right MCS stroke with left hemiplegia. So in this video, as you can see, in the very, sorry for the poor clarity of the video, as you can see, in the initial stage itself, he is trying to do little horizontal movement. Initial stage, when I am telling initial stage, it means he had mild subluxation. That's the reason why I was giving the manual approximation of the joint so that there will not be any secondary complication. The advantage is that at that very early stage we can work for horizontal movements and some aspect of reach. Second part of reach training is reach against gravity, which is very critical. With this device we will be giving reach training horizontally. But the key for upper extremity function is like the ability of persons to reach against gravity. So the key challenge is here is like how you can go in a smooth and graded way from eliminated gravity to against gravity. So how to achieve this? So for that, again, I have just modified or designed this device. This is a hydraulic cutout table with flip-up top. So it allows the top of the table to go for flip-up up to 70 degrees in a graded way, plus hydraulic height adjustment to adjust according to the individual person's height, and the cutout top, which is familiar for all of us. In addition to that, there is two type of scooter board I am using for this particular training. For the left side, the top part, you can see the scooter board which give also support to the forearm. In the second picture, which shows the scooter board which gives support only to the arm part. The difference is like the initial stage for I will be giving training with the first one. In that, patient will be getting support for the hand as well as elbow. So the movement will be little easy. Once the person is well versed with that, we will be going for the next device. So there only the distal upper extremity is given support. So you can see this video. This is a periganglionic bleed. This patient had periganglionic bleed. He came to our department with a flaccid hand. At the end of 3.5 week intervention, see the extension, elbow extension, how nicely he is doing, and the elbow is off the job. So this training we can do. That is the advantage of this device. Then coming to the step 4, training for not grasp retraining. So the tradition, like called the textbook motor control, usually tells like training for grasp at this stage. But I would like to share that if you can give training for the release or the reach activity, reach or release. The advantage is like if at this stage you can give training to the weak synergy pattern improvement. Because as we know, by default the person will get flexor. So on the top of that, at this stage, if you are giving this training, it will be difficult for us to give the training in the later stage. So it would be better to give this first than the grasp aspect or the any movement towards the. And next step, of course, it is grasp. And please remember, there is no much difference, means time difference between these two steps. There will be considerable overlap, like I said earlier. So initially, we will be starting with gross grasp with meaningful activities in a meaningful context. Example, holding a glass of water in a dining table. Now coming to the next stage of training, and this I term like step 6A because these are a continuous process. Here we will be giving training for hand manipulation skills. So here the key consideration is like occupational performance, which is a term used in occupational therapy function, which is nothing but one's ability to carry out roles and functions efficiently. Yeah, a colorful slide. This is in fact the colorful aspect of occupational therapy. So there is 3 important aspects in which we will be working with all of us. Like our working domain is activities of daily living, work, leisure. The important factor here is the context. The environment of mind will be different from you. So the key challenge of an occupational therapist is like to frame activities which is meaningful and purposeful for the individual patient. So here are some examples. The first example will explain about job-specific training for work. So this is this was for a patient. I was making an activity. He had a mild TIA. He was a dentist by profession. He was also an associate professor. So when he comes to department, he was independent in all the area. The problem was like he had mild tremor, because of which he could not carry out his job, especially that drilling with that his equipment. So what I gave is like I made one activity with simple our therapeutic, and I asked him to take out this thermocol ball without breaking it. So this gave him a chance to simulate an activity which is similar to his original law, but without any anxiety. The result was wonderful. After 3.5 week intervention, he will be able to do it independently. Like he was very happy also. So this is how we will be training activities rather than giving any routine exercises. The next example is task-specific training, like in ADA. So this is ADL. So this is a lady with right temporoparietal lobe infarct, so left temporoparietal lobe infarct with so much attraction. As you can see in the video, now see, look at her, the way of holding the comb. Now she is holding the other way. You can see the comb she held it in the other way. When she was doing it for left side, sorry, right side, she could do it quite properly. When it comes to left side, she didn't know to turn the comb. So these are kind of activity where the person is really facing challenge. We'll be analyzing that activity and we'll be giving the treatment accordingly, so that the profession's philosophy to make the person independently in his day-to-day activities, we will be looking for. Similarly, training for leisure. This example initially I was telling that about that civil engineer who had. Please see this. So I have given a dual task, in fact multiple tasks, training for it. Look at the play, it is very interesting. I was playing that movie, Beautiful Mind. In that, when John Nash proposes that girl, see, look at the plate, it is acutely going down. There is nothing wrong in that. The thing is, you can see that. So these are the real life situations. So the key success of rehabilitation is identifying that and giving treatment pertaining to that, than giving a gross reach grasp release training. Yes. Initially, in between he made an attempt to correct it. This was the initial thing.
If it is reverse, John.
Yes. Then next is diagnosis specific pre-vocational training. This is the other aspect. Just the hand function training would not be sufficient. We have to make sure that the patient is going back to his original role. So again, the same person, look at his perceptual motor behavior. And remember, he is a civil engineer working in India. So I'm just stopping that. So now the step 6B is bilateral hand coordination training. So most of our ADL activities, we use bilateral hand coordination. Here eye-hand coordination is very much important. Then the 6th step is transfer of learning, very crucial, because the fullness of rehabilitation lies when the learning an ideal environment, which is department, when it is transforming to the real environment. So transfer of learning should happen to ADL, work, leisure. So these are the pre-vocational training unit we have designed in our center. So this will allow us to give training in standing and reaching, sitting and reaching, bimanual hand activity, all these things. And this is our kitchen simulation area. And this is how, I'll just show one video, how we are giving reach training. So this lady has extrapyramidal symptoms also that she had on the stroke, giving paralysis only. Similarly, homemaking skill training. Yes, spasm. She has a lot of spasticity in her hand. So look at the way of here, as you can see, she is compensating the limitation of shoulder forward flexion with the trunk. So these kind of small things we can identify only with the activity analysis. So now intervention for group 2, which is step 1 to 3 are same. So we'll be giving training for a gross grasp, at least half of the range, so that they will be able to do gross grasp movement. Then individual weight bearing will be given. Then technology equipment like Setoflex handle we can use. So far I haven't given, but option I'm just explaining. Then for the unaffected hand, we have to give compensatory one-handed techniques handle. Then the intervention for group 3 is for flaccid hand to prevent PCDs, shoulder subluxation management, proper handling, prescription of sling if it is needed. And for hypertonic hand, to prevent PCDs, to ease ADL and all the other trainings, passive range of motion exercises, and compensatory techniques to unaffected hand. And coming to the take-home message, post-hoc upper extremity rehabilitation should be based on diagnosis-specific and prognostic-oriented treatment planning. And the focus of therapy should be on functional independence, not to reach grasp release. These are my key references. All with my colleagues, friends, and my